صباح الخير. كل سنة وانتم سالمين مناسبة شهر رمضان المبارك. الحمد لله بسلامتكم، وإن شاء الله تكونوا جميعا والأهل بألف خير وصحة وسلامة. واشتقنا كثير إن نشوفكم، والله نتمنى لكم تمام الصحة والسلامة. اليوم موضوع محاضرتنا عن Temporomandibular joint. مواضيع المحاضرة تشمل gross anatomy of the temporomandibular joint, articular surfaces, intra-articular disc, synovial membrane, developing condyle, and some clinical considerations. Temporomandibular joint is an articulation between the mandible and the temporal bone of the skull. It's synovial articulation between the mandible and the cranium. That's why sometimes it's called craniomandibular joint. Cranium is another word for the skull. It's a hinge joint with a gliding movement. The articular surfaces are covered with fibrous tissue, and the bone of the bone that contributes to the formation of the temporomandibular joint are formed by intramembranous ossification. Both the condylar process and the temporal bone are formed by intramembranous ossification. The joint cavity is divided into two joint spaces by an intra-articular disc that divides the joint cavity into upper and lower compartments. Now I'll talk about gross anatomy of the temporomandibular joint. The temporomandibular joint is an articulation between the head of the condyle. It's also called the mandibular condyle, and the mandibular fossa, which is a depression in the temporal bone. It's called the mandibular fossa, but it's part of the temporal bone. It's also called the glenoid fossa. Also, we have a capsule all around the temporomandibular joint. Also, we have supporting ligaments, including temporomandibular ligament and other accessory ligaments. Also, we have a disc dividing the joint cavity into upper and lower compartments. This is called intra-articular disc, and you can call it articular disc, that's fine. The mandibular fossa is an oval depression in the temporal bone. You see here, this is the depression area, which is called the mandibular fossa or glenoid fossa, anterior to the external acoustic meatus. It's located anterior to the external acoustic meatus, which is here. Variation in the curvature of the glenoid fossa or mandibular fossa, and that is thought to be related to the different types of occlusion between people. The intra-articular disc molds the shape of the fossa and the condyle. Here we have also elevation here anterior to the glenoid fossa, which is part of the temporomandibular joint. It's called articular eminence. This is the condylar process, and this is the head of the condyle that makes the articulation with the glenoid fossa. Mandibular condyle has variation in size and shape. The long axis of the condyle is not at right angle with the ramus. The articular surfaces are the convex anterior and superior surfaces of the condyle. It joins the ramus through the neck of the condyle. As we can see here, this is the ramus and this is the condyle. So it's not at right angle to the ramus, and it's not in line with the ramus. So there is sort of obtuse angle between the long axis of the condyle and the ramus. Capsule. It's a thin cuff of fibrous tissue, doesn't limit mandibular movement, it's too weak to provide support to the joint. It's attached to the glenoid fossa, articular eminence, and the neck of the condyle. Posteriorly, it's associated with the connective tissue of the intra-articular disc. Internally, it's attached to the intra-articular disc and lined by the synovial membrane. It's richly innervated. Synovial membrane lines the inner surfaces of the capsule and the margins of the disc. It doesn't cover articular surfaces. It secretes synovial fluid that fills the joint cavities, and this fluid lubricates the joint and provide nutritive functions. Okay, in this figure we see here the head of the condyle. It's called the neck of the condyle. Here we see the glenoid or mandibular fossa. Here we see articular eminence. Here we see the intra-articular disc. See, the intra-articular disc is dividing the joint into lower joint compartment and upper joint compartment. Posteriorly, the disc divides into two laminae. One is called superior lamina, and the other is called inferior lamina. That's why this zone of the disc is called the bilaminar zone. It has superior lamina and inferior lamina. Anteriorly, you see the disc, the intra-articular disc, is bound to a muscle, and this muscle is called lateral pterygoid muscle, and this muscle plays a key role in the initiation of opening of the oral cavity. When this muscle contracts, it pulls forward and downward. The disc and the head of the condyle, because it's bound to both. It's bound to the disc and bound to the head of the condyle, and by this action it initiates the opening of the oral cavity. Then another muscle continues the opening process of the oral cavity, which is the digastric muscle. The temporomandibular ligament is one of the ligaments that provide support to the temporomandibular joint. It's actually the main ligament that provides support. It's the strongest ligament of all the other ligaments that provide support to the temporomandibular joint. It strengthens the joint capsule, restrict distal and inferior mandibular movement, resist dislocation during functional movements. It originates from the lateral surface of the articular eminence and inserted in the posterior surface of the condyle. Here we see the lateral temporomandibular ligament, which is here. You see it extend from the area of the articular eminence here and to the condyle, insert in the condyle. This is the joint capsule. It's all around the temporomandibular joint, but it's weak and doesn't provide support. The main support is from the lateral temporomandibular ligament. There are other ligaments that provide support as well. This include the stylomandibular ligament extending from the styloid process and insert in the angle of the mandible area. There is also a sphenomandibular ligament, which is here. You can see it better from the inside. Sphenomandibular ligament from the sphenoid bone to the lingula of the mandible, which is located near the opening of the inferior alveolar canal, also called the mandibular canal. The opening of the mandibular canal where the inferior alveolar nerve artery vein enters inside the mandible. Accessory ligaments include, we mentioned the stylomandibular and the sphenomandibular ligaments, and also there are other two ligaments. The other two are called pterygomandibular raphe and the retinacular ligament. So the accessory ligaments include stylomandibular ligament, which extends from the styloid process to the angle of the mandible; sphenomandibular ligament, which extends from the spine of the sphenoid bone to the lingula near the mandibular foramen; pterygomandibular raphe, which extends from the pterygoid hamulus to the retromolar region of the mandible. Retinacular ligament extends from the articular eminence into the fascia of the masseter muscle. Now we'll talk about the intra-articular disc. It's a dense fibrous tissue. It has peripheral blood vessels only, so no blood vessels in the center. The upper surface is concavo-convex from the front to the back because it molds the shape of the glenoid fossa and articular eminence. See here, glenoid fossa, here articular eminence. The glenoid fossa is a depression area, articular eminence is an eminence, so it's more elevated. So the disc in the area where the fossa is should be convex, and in the area where there is articular eminence should be concave. So it's concavo-convex anterior-posteriorly. Lower surface is concave because the lower surface is opposing the condyle, and the condyle is a convex, so it would be concave. And because anterior-posteriorly from the upper side is concave or convex, and inferiorly it's concave, this will make this region very thin, and this is the mid region where we can have higher chance of perforation when there are problems with the TMJ. Lower surface is concave, thinnest centrally and thickest posteriorly. You see, posteriorly is thickest, centrally is thinnest. Here is thinnest, here is thickest. Lateral half thinner than medial half. Here we see a section, longitudinal section in the temporomandibular joint area, and the mandible is slightly depressed, so the mouth in this case is slightly opened. Here you see the head of the condyle, it's convex. Glenoid fossa, its depression area, articular eminence, convex. Now the disc mold all these structures. Posteriorly upward convex, anteriorly upward concave, downside all concave, because it molds, it's against the convexity. The head of the condyle, convex, so it should be concave from the downside. From the upper side, posteriorly convex, anteriorly concave. So we see this area in the center is the thinnest, and the area in the back is the thickest. Here we see the muscle, the lateral pterygoid muscle. Here we see lower joint compartment, upper joint compartment. Also you can call it lower synovial cavity, upper synovial cavity, and they contain fluid, nutritive fluid and a lubricant. That's called synovial fluid. Posteriorly, as we say, the disc divides into two laminae. That's why it's called bilaminar zone. Continuing with the intra-articular disc. In the anterior part of the intra-articular disc, the collagen fibers run anterior, posteriorly, and mediolaterally. In the mid region, which is in the intermediate part, it's the thinnest and is in contact with the articular surfaces of the condyle. And the collagen fibers here in this part run only anterior-posteriorly. No mediolateral direction for the collagen fibers. Posteriorly, the posterior part of the disc, the collagen fibers run anterior-posteriorly and mediolaterally. So to summarize, anteriorly and posteriorly, the fibers run anterior-posteriorly and mediolaterally. In the intermediate region, they run only anterior-posteriorly. On the peripheries, the disc merges with the capsule. Anteriorly, it's attached via fibrous bands to the anterior margin of the articular eminence above and the anterior margin of the condyle below. So it's bound to both the articular eminence and the condyle, medially and laterally attached to the capsule, posteriorly attached to the capsule via bilaminar zone, superior and inferior laminae, as we explained before. Superior lamina, inferior lamina. Okay. The innervation of the temporomandibular joint. The temporomandibular joint is considered richly innervated. Some of these nerves are involved in proprioception, which means mechanical sensation or pressure sensation. And other nerve endings are involved in nociception, which means pain sensation. Proprioceptive nerve endings are involved in reflex control of mastication. For example, when we eat something hard, when we chew accidentally on something very hard, then the pressure will increase dramatically inside the temporomandibular joint, and this pressure will be sensed by these proprioceptive nerve endings. They send the message to the central nervous system, and the central nervous system send the order to the muscles that are responsible for continuing the chewing process, and they are ordered to stop chewing, to stop contracting. And then we stop chewing, then we protect our teeth and oral cavity from biting on such a very hard object. This is called reflex control of mastication. The nerves that contribute to the innervation of the temporomandibular joint include the auriculotemporal, mesenteric, and deep temporal nerves, and all are part of the mandibular division of the trigeminal nerve. Articular surfaces. The head of the condyle has 4 layers. Now we are talking about the histology of the layers of the articular surface of the condyle. The most superficial articular surface is composed of fibrous tissue. So the most superficial part of the articular surface of the condyle is fibrous tissue. It's basically collagen fibers and fibroblasts. Not many fibroblasts. The majority is just collagen fibers. Then below this fibrous layer we have a cellular zone where proliferation occurs. It's also called the proliferative zone or the cellular zone. Then we have a fibrous layer with variable appearance and cartilage-like cells. This is called the fibrocartilaginous layer. Then we have a layer of calcified cartilage directly covering the bone. Then of course we have the bone. The articular surfaces of the mandibular fossa is very similar, only thinner. So the same layers that we find here in the articular surface of the head of the condyle, we have the same layers in the articular surface of the glenoid or mandibular fossa, but the most of these layers are thinner in case of the mandibular fossa. Here is a histological section of the articular surface of the condyle. See, first layer is the articular zone or the fibrous zone. It's collagen fiber plus few fibroblasts, not many. We have cellular zone, proliferative zone, which is highly cellular, where proliferation, cell division take place. Then we have this layer, the fibrocartilaginous zone. This zone is both collagen fibers and cartilage, so it's mixed. Then we have the calcified cartilage zone, which is cartilage but it's calcified. That's why it appears more darker. It appears darker than normal cartilage. Then we have the bone, which is the bone of the condyle. It's called the subarticular bone. So the bone is not part of the articular surface. It's below the articular surface. The articular surface include these four zones: articular zone, proliferative zone, fibrocartilaginous zone, and calcified cartilage zone. Here we see the disc, which is fibrous tissue, mainly collagen fibers and few fibroblasts. It's same nature as the articular zone of the articular surface of the condyle, and also the articular zone of the articular surface of the glenoid fossa. Here we have the lower joint cavity. Here we see the glenoid, the articular surface of the glenoid or mandibular fossa. We have the same layers. We have the articular zone, proliferative zone, fibrocartilaginous zone, calcified cartilage zone but very thin. Then we have the temporal bone. You see here the articular zone is thicker, but the other layers are thinner. The proliferative zone, fibrocartilaginous zone, calcified cartilage zone, all very thin. This is the articular disc, and this is the superior joint cavity. The intra-articular disc is dense collagenous fibrous tissue. Fibers run in anterior-posterior direction in the middle, mediolateral and superior-inferior direction, as well at the anterior and posterior end. So we find anterior-posterior direction for the fibers in all parts of the disc. But in the anterior and posterior end, plus the anterior posterior direction, we find mediolateral and superior inferior directions. So basically in all directions, there are fibers running in all directions in the anterior and posterior parts. But in the middle, only we have anterior posterior direction. More convoluted appearance anterior posteriorly. The fibers running anterior posteriorly have more tortuous or convoluted appearance. Convoluted appearance means like this. This provides the fibers more ability to withstand stretching. When they are stretched, they are not torn. When they are tortuous like this, if they are straight like this, Then if they are stretched, there is high chance for that the fibers will be cut. The fibers of the articular disc at the peripheries have a circumferential arrangement. Also, we notice under the electron microscopy images that there are dark and light bands at very high magnification of these fibers, of the collagen fibers of the articular disc of the temporomandibular joint. These dark and light bands, dark, light, as you can see, indicate crimps or waviness of the fibers. Crimps or waviness of the fibers is important for biomechanical properties of the connective tissue. It has a greater ability to withstand stretching. The chemical composition of the disc. It has collagen fibers. We have 3 types of collagen fibers. The main collagen fiber is collagen type 1. It makes up 80% of the dry weight of the disc. We have also collagen type 3, but it's in small amounts. We have collagen type 2 in localized areas of fibrocartilage. So sometimes we find fibrocartilage inside the articular disc. That's why we find collagen type 2, because it's well known that collagen type 2 is the cartilage collagen. Wherever you find collagen type 2, it means there is cartilage. So when in areas where we have fibrocartilage in the intra-articular disc, in those areas we find collagen type 2. We also have elastic fibers in the disc. Also, the disc has ground substance, and this ground substance make up 5% of the dry weight of the disc. 2/3 of the ground substance is chondroitin sulfate and 1/3 dermatan sulfate, and we have traces of hyaluronan and heparan sulfate. So the majority of the ground substance is chondroitin sulfate followed by dermatan sulfate. The majority of the fibrous matrix is collagen type 1. Now we'll talk about the cell population or the cellular component of the disc. The cells of the disc are more abundant at birth. Variation between flattened and rounded cells. So we have 2 types of cells in the disc. We have flat and rounded. Flat are the fibroblasts that produce collagen, and rounded that are the cartilage-like cells that produce cartilage, collagen type 2 cartilage. Moderate amounts of endoplasmic reticulum. So these cells, cellular population of the disc, have moderate amounts of endoplasmic reticulum. Means they are involved in protein synthesis. They have intermediate filaments. They have plasma membranes adjacent to extracellular collagen fibers. these cells are called fibroblasts, or should be called fibrocytes. Why? Because they, especially with age, their activity become less and less. So they have low activity. So where the term fibrocyte will be more appropriate for them, but they are still called in the textbooks fibroblasts. But it's just a suggestion that the term, we keep in mind that the term fibrocyte would be more appropriate because they are less active and they are not anymore dividing cells, proliferating cells. As we mentioned before, there are some localized fibrocartilaginous areas in the disc. The cells in these areas have a rounded appearance, and this is reminiscent of cartilage cells in lacunae. They look similar to the chondrocytes, the cartilage cells in lacunae. Interface between cells and lacunae stain with Alcian blue and toluidine blue. So around these cells, the round cells in the intra-articular disc, if you use the stain Alcian blue or toluidine blue, they will stain positive, the periphery of these cells. This means there is collagen type 2, because these stains, Alcian blue, toluidine blue, they stain collagen type 2, and they are commonly used to stain cartilage. Pericellular matrix with microfilamentous material associated with aging in the mouse. So the presence of fibrocartilaginous areas have been found to be more have been proven in mice, in laboratory mice, to be a sign of aging. So the more aged the mouse, the more likelihood to find fibrocartilaginous cartilages in the disc. And this is likely to be the same in humans. It's likely that the presence of these fibrocartilaginous areas correspond increases with advancing age. Some suggest the presence of fibrocartilaginous areas as pathological, but this is not proven. The most accepted theory is that these fibrocartilaginous areas are more a sign of age rather than pathology. Nutrition, where the disc gets its nutrition. The majority of the disc is avascular, and we know that the main source of nutrition comes from blood. But because the majority of disc is avascular, so we need another source of nutrition. There are blood vessels in the peripheries, and this is a source. But this is not enough, so we need another source. Diffusion from the synovial fluid is the second source of nutrition. Superior lamella of the posterior part has numerous vascular spaces. Also, the superior lamella of the bilaminar zone is richly vascular. So this is also contribute to the nutrition. Changes in blood flow with jaw movement. The amount of blood flow changes during the movement of the mandible. Now I'll talk about the synovial membrane. Synovial membrane is the membrane that produces synovial fluid. It lines the inner surfaces of the capsule. Doesn't cover the articular disc. Flattened endothelial-like cells on a vascular layer. So they are basically, synovial membrane basically have two layers. Vascular layer, which is here, and endothelial-like layer. The cells in the superficial layer are two types. One type is macrophage-like, and the other type is fibroblast-like. If we go to this more magnified, you see here is the vascular layer, or you can call it vascular subintima. And then we have the superficial layer, which is the intimal layer. And you see here some cells are macrophage-like cells, like this cell here, and some cells are fibroblast-like cells. They secrete the synovial fluid to the free surface here, which is the joint cavity in this case. Here is the same thing. You have the intimal layer where the cells are, and the vascular layer where the blood vessels are. This membrane folds at rest. This membrane show increased projections with age, and this membrane has great metabolic activity and high regeneration abilities. I'll talk about the synovial fluid. Synovial fluid is secreted by the synovial membrane. It occupies the joint cavities, so the upper joint cavity, lower joint cavity, they are filled with synovial fluid. We have around 1 ml of fluid in the inferior compartment, slightly more in the superior compartment, because the superior compartment is slightly larger than the inferior compartment. That's why we have slightly more synovial fluid in the upper compartment compared to the lower. It plays an important role in lubrication and nutrition. It contains synovial fluid, proteoglycans, the pressure or the hydrostatic pressure of the synovial fluid varies according to the according whether the mandible is at rest or being used for chewing food. So the hydrostatic pressure at rest is subatmospheric, less than the atmospheric pressure. And the hydrostatic pressure greatly elevated during mastication. Developing condyle. The histology of developing condyle is slightly different from the histology of adult condyle. Some of the zones are the same and some are different. The first zone and the second zone is the same. The first one is called the fibrous articular zone. Second one is proliferative cellular zone. They are the same, but they are more cellular because for young children condyles, we expect to find more cells, whether in the fibrous layer or the proliferative zone layer. And see, the cartilage zone is much larger than in case of the adult. In the adult, we have a narrower, we have two layers. We have fibrocartilaginous zone, and beneath we have a narrow zone, a much narrower zone of calcified cartilage. Here we don't have fibrocartilaginous zone in the young condyle. We don't have fibrocartilaginous zone, and we do not have calcified cartilage zone. We have what is called condylar cartilage, and beneath we have endochondral ossification zone. And the condylar cartilage have different layers. We have the different layers or zones. We have the hyperplastic zone, where we have division of the chondrocytes, active division of the chondrocytes. We have hypertrophic cartilage zone. We have a little bit of calcified cartilage zone that's just before being replaced with bone, but it's not like a thick layer like in the adult condyle. Secondary condylar cartilage appears at 10 weeks in utero. The condylar cartilage, as we explained in the oral embryology 1 lecture, that is classified as a secondary cartilage because it appears after the mandibular bone starts to form, while Meckel's cartilage is considered primary cartilage because it appears before the bone starts to appear. Proliferation site till the later half of the second decade. So the condyle continues growing until the later half of the second decade. The condyle is lined by fibrous tissue overlying a proliferative layer. Cells from this layer give the fibroblast-like cells which will differentiate into chondrocytes. The condyle turned into bone, or the majority of the condyle is turned into bone by a process called endochondral ossification. Chondrocytes do not form columns. The chondrocytes in the condylar cartilage zone, they do not form columns like the case with the case in long bones. The long bones, all bones in the body are the bones that are formed by the process called endochondral ossification. They first formed as cartilage, then turned into bone by a process called endochondral ossification. And in the long bones, the chondrocytes are arranged into columns, while here in the condyle they are not. Now we compare primary versus secondary cartilages. Keep in mind, Michel's cartilage is considered primary cartilage. Condylar cartilage, mandibular symphysis, and the coronoid process of the mandible are secondary cartilages. Also, the long bones, the cartilages that mold long bones before they become bone, is considered as a primary cartilage. Primary cartilages map out the shape of the future bone, and the shape of the future bone is already mapped in secondary cartilage. So in long bones, the cartilage map the shape of the future bone, but condylar cartilage or coronoid cartilage or mandibular symphysis cartilage, they do not mold the mandible. The mandibular bone already exists. The most of the parts of the mandibular bone is formed, and these are additions to the main parts, the secondary cartilages. So the condylar process, the coronoid process, mandibular symphysis appear as cartilages after the majority of the mandibular bone is formed. The bone of the mandible is formed, so they do not map out the structure, while in long bones, the entire bone is formed by cartilage first, then gradually turned into bone. Primary has an inherent growth potential, and this growth potential is limited in the secondary. Primary could have proliferative zones in both sides of the central region. So in long bones, we have a shaft of the bone, and we have two ends. That's why the proliferation is in two directions on both sides, while in the condyle, which is an example of secondary cartilage, we have the proliferation in one direction. In primary cartilage, chondrocytes are arranged in columns in the direction of growth, while in secondary cartilages we do not have arrangement in columns. Primary has more extracellular matrix. There is more extracellular matrix in primary cartilage. Why? Because primary cartilages make bigger structures, like long bones, for example. So we need more abundance of extracellular matrix to make a bigger size structure. In the secondary cartilages, for example, the condylar process, we do not need that much extracellular matrix because the size is small. Secondary can provide growth in more than one direction, while in the primary we have two directions, two sides around the center, so we have two directions. But in the secondary, we have multiple directions. Now we'll talk about some clinical considerations. Rheumatoid arthritis and osteoarthritis are two types of arthritis that affect the temporomandibular joint. But most commonly, rheumatoid arthritis affect the temporomandibular joint more than osteoarthritis. Because it's generally considered that rheumatoid arthritis affect small joints and osteoarthritis affect large joints. And the temporomandibular joint is considered a small joint. That's why it's more susceptible to rheumatoid arthritis than osteoarthritis. But still, we have some cases of osteoarthritis affecting the temporomandibular joint. Internal derangement of the disc internal derangement of the temporomandibular joint include displacement of the disc anterior-medially, and when this happens, we'll have two scenarios. Either we have clicking in the joint. This is called anterior disc displacement with reduction, that the disc is displaced anteriorly and it becomes an obstacle to the condyle to bypass the disc. When it bypasses the disc, we will hear clicking, and then we have normal mouth opening. There's another type, it's called anterior disc displacement without reduction. Without reduction means the disc is anteriorly displaced and the condyle cannot bypass the obstacle of the disc being displaced anteriorly. And then we have limited mouth opening. We will not have clicking, because clicking takes place when the condyle can pass the disc obstacle. But in case if it couldn't bypass the disc, then we do not hear the clicking, and what we will have as a symptom is limited mouth opening. And the normal mouth opening is about 3 fingers. 3 fingers, the size of 3 fingers put in vertical manner. This is the considered the normal mouth opening. Also, internal derangements of the disc could include pain in the joint, clicking sound. We explained that when the clicking take place, restriction of mandibular movement, represented as a limited mouth opening, degenerative changes and changes in the disc shape. Degenerative changes if left untreated, they may lead to perforation of the disc. Also, internal derangement of the TMJ include degeneration in the articular surfaces, which is associated with rheumatoid arthritis and osteoarthritis as well. Any of the signs that signal that there is a problem in the TMJ, any of these, whether it's pain, whether it's clicking, whether it's restriction of mandibular movement, so any sign that we can find that tell us that there is a problem in the TMJ, we should immediately refer the patient to the maxillofacial surgeon so that they can do further assessment of the situation and do proper treatment. Occlusal changes lead to changes in the TMJ. So if there is a problem in the occlusion of teeth, for example, after extracting one of the teeth and leaving a space without replacement, the teeth will start to close the space by tipping and drifting, and this will disrupt the whole occlusion in the oral cavity, and this will lead to problems in the TMJ. Also, if we have, for example, a filling that's not done properly, or a crown or a bridge that's not done properly, this may affect the occlusion and affects the TMJ. It's very important not to disrupt the occlusion. Thank you very much. I really appreciate your time and attention, and looking forward to seeing you face to face as soon as possible, and wish you all the best. This is the last lecture of this semester, and we look forward to seeing you in the near future. Take care of yourself and your family, and wish you all the best. Bye bye.